goals for this meeting tonight are to start building that team. And anybody who is new to this aspect of HCAO, we're building you into the team. And to use our time together to discuss and practice some of the techniques, the strategies, the tactics that we think will be especially effective for building this kind of statewide support through a community conversation. And Mike and I put together a four-topic progression for this next hour that includes starting with things we would talk about all together, using and modeling and developing and practicing this strategy of community conversation. So we want to talk, what's it like to have a conversation about values? What does it mean to be persuasive? How do we adopt persuasive strategies that will help us win that support? What can we say? What can we talk with people about the cost of this program? Because so many people the right wing has bamboozled people into thinking it's going to be more expensive. We know it's going to be less expensive, but how do we have a conversation with people about that? And how do we motivate people in our community conversation groups to a call to action to become even more active than they were? So the first topic is conversing about values. And the question is why? Why, if you're going to start a conversation with people in the community, why do you want to start with values? Anybody got any ideas?
Something people can probably agree on, starting on a positive note, maybe.
Yeah, and if you can't agree on values, then the conversation may be a non-starter to begin with.
It may be. One of the things that I'm learning, is that there may be values held in common across the political divide in Oregon about healthcare. And if we start with shared values, we will not have to start with, I don't like your way because, and you don't like my way because. We won't have to start with that. We want to start with what we can agree on. So we want to start especially trying to identify shared values. And I must confess, I am not so sure about this, because I have given talks and programs about universal healthcare for many years, for probably 10 or more years. And I have always started with, what are the problems? What's wrong? And I find the most horrifying stories and the most amazing statistics that will make the audience get all emotional and get afraid and get angry, build up their emotions so that then they'll be willing to want to come and support the movement that will get rid of all this terrible stuff. And that might still be the best strategy. I don't know. I haven't practiced this start with values stuff enough. In fact, this is the first time I've even talked with a Zoom group about it. So one of the things we want to do tonight is, as we see what starting with values does and what the conversation model does, is remain open-minded that we may want to change it. You're part of the team. This is a team where everybody's opinion matters, because nobody's opinion is, sanctified. So I'm still not sure about it.
Bruce raised his hand.
Bruce, yeah, go ahead. Oh, you're on mute. Unmute, Bruce.
Also, everybody, you can use the electronic hand raise, and that helps us keep track of who's in line.
Oh, yes, thank you.
It seems to me like Sandra, is it Sandra or Sandra?
Sandra.
Sandra. Seems to me like you are starting with values, because you're asking, you're raising issues. You're talking about what is important to people.
That's it. That's it. And the next question is, how do we do it? So one of the ways to do a community conversation, as opposed to a speech from the stage, speech from the podium, is to ask the audience an open-ended question where you really care what they say in response to that question, and then give them a chance to answer it. So you can start a conversation with the group about values by saying, you might even be behind a podium. You might be in a chair in the front where nobody will sit next to you because they think you're the leader. But if you start with a question, might get people to start talking about values. Now, the one I put on the slide here is, I don't like it yet. It needs to be revised. What values and principles should shape our healthcare system? It's got too many words in it. It sounds wonky. It sounds too academic. It sounds remote from people's lives. And that's the kind of thing that I've found in working with Mike and John. Over time, we are able to revise these things and make them a little more friendly, and possibly to elicit an audience response. But we're new on this value thing. So all this stuff on the bottom here is the speaker notes for this slide. And we're thinking about other questions that one might ask that would launch a conversation on values, such as, imagine a place where everybody has such and such and such, and then put in something, what's key for you about universal healthcare. Imagine a place where if you're sick or you have an accident and you go to the doctor, you don't have to pay any money for the care that you will get at that point. Even that's too many words. So this is the kind of stuff that really needs wordsmithing. The questions you ask the audience to elicit the conversation are important. If you or your family lost the employment, what would you do? How would you want society to treat you? What do you want? What values do you want your healthcare providers to have? Those are some, I would suggest asking one question and then see what you get. And if you don't get very much response, then ask another one. If you use the electronic hand raise function, it'll go to the top of the little face strip I have here, and I'll know it. So let's see, let's try it. Imagine that somebody came along and asked us, what values and principles should shape our healthcare system? What would you say?
Quality healthcare over
Quality.
profits.
Huh? What was it?
Over
Quality and what?
Quality over profit.
The great phrase, of course, that our movement uses is patience over profits. I love it.
Like,
what else?
I will try to be concise with this description, but like, there's so many ways that people talk about the price or about like how payment is involved in the process. And so to have that be totally excluded from the conversation and just have like somebody's care, just like,
Yes.
I'm just kind of reinstating the same thing, but just like not even, I value not even mentioning how will you pay for this because it shouldn't matter. Anyway, yeah, lots of nuance.
Have money not be in the middle of the care conversation between patients and providers. Yeah, that's a good point. Allison.
Equity. And that kind of touches on all the other points. Like people should get what they need and not take into account how much it costs.
Yep. Oh, don't you wish that would be so? You haven't said affordable. I'll chip in there. I'm a conversationalist here. Mike, unmute yourself, Mike.
Yeah, might have to do a little dance around the cost question because that's often the first question. And you don't want to seem evasive, but you could say, I think I have some possibilities later, but I just want to know what's important to you right now.
Yes, that's a good way to get off of a topic. But an awful lot of people will say quickly that healthcare is too expensive and they want a healthcare system that's not so expensive. We will give them the details at some point, but that's where people start.
Allison's got her hand up.
Allison again.
I wonder for these conversations, what type of audience are we engaging with? Is this an audience? Okay, it ranges. So something that I wonder, especially for audiences that are maybe not as familiar with the concept of, or like what is in the realm of possibility, who are stuck in the status quo, who have no other lived experience, it's kind of hard to imagine what a different system could look like because they
That's
may
right.
not know. So I wonder if like a different entry point would be like, and maybe this is something you guys have discussed internally, so feel free to just say, "Oh, we talked about that." But like, have you or a family member ever like delayed or did or like avoided
Right.
care
Mhm.
because you couldn't, or like, for whatever reason? And then maybe that could be another entry point to like, is that what we should be valuing? Or I don't know, like just some other way to help people imagine like what could be different if they don't know.
Yeah. And that's the
Timeliness.
goal. That's
Timeliness.
exactly the goal, is to imagine that something could be different. And however you get there, uh, you do whatever works. But if we start with how bad things are today, we are not going to get to a happy place. We have to find a way that the start is about possibilities. It's about hope. It's about difference. It's about values. It's about something good that we are aiming for. Some of the stuff you can read about advice to Democrats and progressives about how to promote our program and our candidates is that Democrats are accused of being stuck in the rut of telling everything that's bad, stuck in the rut of loud complaining, criticizing, maybe even an attack mode, and that if Democrat-based, left-wing-based campaigns would start with values, start with why, start with what kind of society are we looking for, start with why this is a good thing, we can avoid getting in that rut. I
Colin's
think,
got his hand up.
yeah, go, Colin.
Yeah, I was just noodling while we've been sitting here about how like if we start off or it's starting off with this kind of open-ended question about like what values do people want, like it's so hard to break me and everybody out of this the very confusing reality of our bad broken healthcare system, right? And so maybe starting I would maybe start with an example of like I imagine I imagine a place that is a system that is set up where you receive quality care that you know is like good and you know is comparable to what everyone else in your community is getting, and you can walk out the door and imagine a world where you walk out the door of the clinic or the hospital after any sort of treatment or whatever, and you don't have to worry about payment. Like you know that the moment you walk out of your treatment, it's over. You're done with the conversation. And that's what I personally want. That's not really a value, but like maybe each of us saying like something, or like if we're giving a presentation or hosting a conversation, like each of us saying like the best case scenario for us that could might spark somebody else's like, you know, response.
What you're making me think about is the difference between talking about values, which are kind of abstract, and talking about sort of real life scenarios that embody the values and that are something that we want. The thing that we have to avoid, and it's hard for me, maybe it's easy for you all, but it's hard for me, is not to stand up in the front of the room and say what I want.
Oh
How
yeah,
do
that's
we
true.
how do we have a conversation where we get the other people in the room who haven't thought about this as much? How do we get them to say what they want? And that's the trick. And the suggestions we put in here of what kind of questions you could ask. This is a beginning stage. This is new for all of us. We've got to work on this together. I would imagine. I mean, it's a good thing we have probably till 2026 or 2027, because we're going to have to do some work to evolve a better way to talk about this. Amanda.
Bruce, yeah, and then Bruce.
Okay.
Yeah, I think that's a really, really good point, and I really value all of your insight. I wonder if it could be something like one example might be, so it's not quite as personalized, not like what I want. And then maybe this prompt could be slightly different. So this is, example of what, I would imagine in a healthcare system. What about you? What do you want your healthcare provider to be focused on? So taking one of these beautiful prompts that you have below and using that as kind of what the discussion's based on, maybe? If we're worried that having people
Yeah.
imagine healthcare in general is a little too nebulous.
Yeah, I
Yeah.
agree. I like the prompts that you have below. Kind of getting to Colin's point and to Amanda's point of like
Mhm.
starting with a scenario that they can respond to of like, if this were to happen, what would be the ideal scenario? You know, how would you wish this would play out if this kind of
What a
thing
great
happened to
idea.
you?
Oh, we could work on that.
And it's
Tell
kind
me,
of
tell me again, Hannah. Say what you said again.
Yeah, so like just I mean, I feel like I'm just reiterating what Colin and Amanda were getting at, but like posing, setting up a scenario. And you've got one like right here at the top, I think, like if you or your family lost employment that provides you health care, like
Yeah.
I think the way you have it there is, how would you want society to treat you or whatever, but maybe you could reword that to if you or
Yeah.
a family member were to lose your employment and therefore your health care, or like if you were to lose your employment, how do you wish that could uh affect your healthcare or something. I'm not coming up with something very good here at the moment, but setting up a scenario and then saying, if this were to happen to you, what would be the ideal of how it could play out that would be best? Like
Right.
imagine the best scenario. You lose your job. What's the best scenario for your healthcare? Like, and I would imagine people would be like, well, it would be great if I didn't lose my healthcare if I lost my job. So
Yeah.
you're kind of setting them up maybe, but
And I
Yeah,
would think,
I think we can go with that. I would, if any of you want to join the team of Mike and John and me and help actually rewrite these slides, let us know. But I think we can go with that.
Bruce
Colin.
is not
Bruce.
electronic, but then
Bruce,
Colin.
okay.
so I kind of shaped that question into, if your family member whose employment provides health care lost his job and your family lost their health care, how many ways would it affect the people in your family?
Mhm.
Because it's a lot more than just health care that it affects actually.
Mhm.
And especially pushes people towards jobs they might not like. But what I was going to talk about before was opening the whole conversation. What I've been doing lately is experimenting with openers, and I've been just starting with an open. Let's be imaginative about healthcare. Tell me what your issues are. When you hear the term healthcare, what do you think of? And that's good because it knocks down a lot of those barriers that they're not going to be happy until you talk about them anyhow. So you might as well get to them right away,
Mhm.
But I love this prompt sentence question is really, really nice.
Well,
And
Colin, then let's move on.
Yeah, I think that we could all get real stuck on semantics, and which is exactly what I'm doing right now. But Hannah and Bruce, you both said, somebody loses their job and then you lose your access to your health care. And I want to personally move away from that, because if someone loses their job, they're going to lose their health insurance, which is not the same as health care, which is what we're hoping to get in 2026, 7, 8, And let's say you lose your health insurance, you have somebody down the road who can give you a tincture or whatever. That's still like care, etc.
Yeah.
So yeah, that's something that I think about.
We got to make sure we've got the right word, and especially
Don't be
if it's going
afraid to use that word, huh?
well, if it's going to be in
Insurance.
60-point type in a slide on a screen, it's got to be the right word.
Sure.
So
I mean, yeah.
Yeah,
And also,
it
I think
does.
but each speaker, will have a different thing they want to say, obviously. So
Each person will. Each person will. We're firm believers. When the Speakers Bureau started, there were people who thought, well, what we were going to do is create a set of slides and make everybody use our slides. And we quickly decided, no, we're not going to do that. We're going to find a team of wonderful, creative, imaginative, diverse people, and we're going to support them. We think giving people slides they can use is a support, but we're not going to tell them what they have to do, except you have to support them. You have to support this movement. Okay, the next slide that I put on here, this is an interesting slide because it is the results of a survey of Oregonians. And these are the top values. In August 2024, this survey was published. These were the top values that Oregonians listed. You can put this, especially if you're not getting any responses to a previous question, you can put this slide up there and say, do you want these things in your healthcare system? Do you want them or not? And there's smaller things here. Uh-oh, I just messed this. I moved this to the wrong place. Come on. I'm not doing as well on the screen sharing as I thought I would. Okay, so surveys of Oregonians have asked these questions. How many Oregonians, asking the survey, how many Oregonians do you think would say, yeah, I support universal health care? How many do you think?
More than half.
You can ask your audience this.
Bruce said more than half.
More than half. Where's that slide? There it is. 75%. Now, what does that mean for our movement? If we find a way to get those 75% of people to support, say, what comes out of the governing board, or even just you lose 5 or 10% of them, we're going to win that ballot initiative. The other, that is, and you can see on this slide, if you have people who don't believe your numbers, you can see on this slide, the 21 there is the red 21. Those are the people who said it's not desirable. We got 75% of people who said it was desirable. Allison.
Are those like counts or percentages?
That's a percent. Those are
okay.
percentages.
Okay.
Percentages.
It was a study that Warren George did.
That Warren George did. The another question that we pulled out of that Warren George study was how many Oregons would pay taxes to support universal health care? How many would pay taxes equal to what they're paying now in premiums to support their health care? What do you think? We got 75%.
3.
Huh? How much, Amanda?
63%.
63. All right, there's a number.
Wow.
Can you believe that? 81% favor replacing private insurance.
These are of those who said that was a good idea.
Oh, that's right.
It was a good
of
idea.
Those who said it was, oh, that's right. Oh, I got that wrong, didn't I? Okay, but they're willing to pay a new tax equal to their healthcare costs. Most of us don't have a clue what our healthcare costs is. We're actually paying a lot more than we think we're paying. Anyway, these are good examples of slides. You can use the beginning, the end, but they do suggest to people that the values that we're talking about are winnable.
For my knowledge, I have a question.
Yes.
I do wonder if we have if anybody's taken account of the information about what were the reasons people would be on the definitely not. What were their biggest problems with it?
No, I don't. And the problem is, a problem I see with that is if you ask people what their reasons are, they just are going to parrot back to you what they learned in the echo chamber. They're going to.
It would be nice to know.
Yes, and we know some things. We know what people have said when they've gone to the legislature to testify against the bills that we're trying to get through the legislature. And some of it is, I mean, people will go and rant about socialized medicine when they don't have a clue what program is being proposed or what socialized medicine is. So you got to be kind of careful with that. We'll get to some of that later, and we have to deal with the obstacles that are not solid obstacles. We do have to deal with them. And one of the issues to think about in a conversation is there's very good advice that you should not mention what the opposition arguments are, because this research shows that if you mention the opposition arguments, people are more likely to believe the arguments opposition afterwards than they were if you didn't mention it.
That's not why I was asking. I was asking because it would be important for us to know.
Oh, us to know. Okay. Okay.
I have an answer.
Uh-huh.
If you go to the Elway report, which is blurred out here, and you can get there by focusing your camera on the QR code. And so, and this was, by the way, the LOA Institute from Seattle, one of the top 6 pollsters. It wasn't just Warren George. He had no idea how this was going to come out, but he did invest $25,000 to get the study done. But the resistance comes from vested interest, and 40% cited reasons related to existing actors in the system that would lose money if we had universal health care. 24% mentioned political reasons from politicians to socialism. That's in that category of 6 or whatever, 12%.
Good.
I'm not sure I understood that. Political reasons.
Yeah, I mean, instead of taking time, just if you could go to that
Okay,
LOA report.
I will. Thank you.
And it'll parse it down for you.
Good. Yes, if I worked for an insurance company, I would probably be against it. I understand that.
Yeah, surprisingly, there's a lot of insurance people who work for insurance companies who are in favor of it because they have seen how the sausage is made.
Mm.
So to go back to the how to have a conversation about these things, one thing you might want to do is talk more about what these various values mean. What does universal mean? What does equity mean? What's access? What's quality? What's cost? And ask, but let's skip over that for now because let's move to this bigger question. Are we meeting these values? Because if we generate out of a group a list of values that people think are important in healthcare, then we ask, are we meeting those values? And the answer is going to be no, which is going to lead us to how do we make it better? So equity might be one of the I hope equity is one of the issues we mentioned here, and I hope it'll be one that comes up in every conversation, because there are various sources of inequity in the current healthcare system that show we are not providing equitable healthcare equitably. I mean, the biggest one is that providers get compensated so much less for Medicaid than Medicare, and so much less for Medicaid and Medicare than from private insurers, that there's noticeable tendencies for providers to provide better care for the people who have, will give them a better reimbursement. There are also all kinds of, there's one of the evidence, the pieces of evidence that shocks me is how many people are uninsured. And they will give you this little chart here that you can use that, look at those lines. The top line is Hispanics who've been underinsured various years going back to 2008. And the middle line is Black Americans, and the bottom line is European Americans. And they've all gone down. It's all gotten better since 2014. But the racial differences are still there.
Colin has his hand up.
Go,
Yeah,
Colin.
Sandra, I'm curious to see the some of your notes. I'm wondering if you could slide
Yeah,
up.
how can I
just
get those notes up there?
So use your cursor, and there's that like tiny thin black bar. Yep, close to where your cursor is.
It's hidden by this screen share green line.
Okay. Well, if you just drag that thin bar up a little bit, then we can see like a line or two of
I
your
can't
notes.
see the thin bar.
You can grab the zoom thing and move it to somewhere else on the screen, and then you can grab it.
Grab the zoom thing.
Like the thing that's blocking your view, you're allowed to touch it usually.
I can move this screen sharing thing out of there.
I think you should be able to.
Usually,
Little line that says you are screen sharing.
you can sometimes drag it.
Yeah. So I see your cursor, just like down about a half an inch is the line that will allow you to, right there.
Yeah.
If
Almost there.
you click there, I think we'll be able to see some of your notes, or I'd like to see some of your notes.
I would too. Oh, look, I could get rid of this thing. There we go.
That's what I want.
There we go.
Yeah, even that's great. Thank you so much.
Okay, so I can get a lot more out of that. There we go.
Sure. So I think a happy medium is what I personally prefer. Thank you.
Okay, but this is a good example of the kind of notes that explain the slide. And you can't just throw a slide on the wall. You gotta let people talk about it. So we've got the issues on quality of healthcare. There's slides in here about international comparisons. The thing about international comparisons is a very conservative audience is going to say, I don't care what any other country does. America's the only country that counts. I don't care what any other country does. But most audiences are going to care about it. And the thing that our team was most interested in is what are called avoidable deaths. How many people died who would not have died if they had had adequate health care? So here we have these blue lines. I hope an audience could see that the United States has got more deaths that could be avoided if we had a better healthcare system. Another slide that we like is here are particular conditions which you can probably make the case would be avoidable for many people. And each dot represents a country, but the blue dot is the United States. And why is the blue dot at the bottom of every column, just about? It's almost at near the bottom on almost every column. These sorts of international comparisons that show the US doing so much more poorly than other countries might help people see it could be better. Amanda.
Yeah, I just wanted to ask about the underinsured slide. Some of the kind of pushback that I've gotten is that, well, OHP's expanded and most people are covered. So what's the point of having universal health care? So I was curious if you've gotten that or how you would respond to that.
Yeah, and what we'd love to have is very recent Oregon-only data, but the percentage uninsured in Oregon is very low. It's argued that the percentage of people who are underinsured in Oregon is 50%. We haven't checked out the sources on that, but the point of the uninsured slide is to show racial disparity, not the overall amount of uninsuredness.
Oh, Bruce has got his hand up.
I've got a
Bruce.
really dumb question. I apologize, but I don't see how to raise my hand on the app here. Can somebody maybe?
There's a little react button at the bottom. It looks like a heart, just to the left of the share screen green rectangle.
It says recognize hand gestures or play chime.
Oh,
click on the heart.
Yeah, click on the heart.
I was clicking on the wrong side of that. Okay, thank you. Got it.
Yeah.
Okay. These slides about quality there are several of them. You can pick the ones you like the best. What I like about this one is there's the United States way down there. All the other countries are up there. The United States is way down there. This should make people feel a little less like we have the best healthcare system in the world.
USA.
Yeah, USA. Okay, so why is my screen sharing paused?
Allison has her hand up.
Allison. Yes, go.
On the previous slide, I am confused by the dots. If you go back to the slide that had the different types of healthcare outcomes, like infant mortality, life expectancy.
I can answer that question, believe it or not. Or if you can go one slide up, Sandra. So that's a screenshot from a dynamic chart that's on that website. Sandra, can you go to the previous slide with the dots, the blue dots with the different countries? So on the KPP Pearson, if you take your cursor, anyway, one would take your cursor and you'd hover over a dot and it would say Japan or Netherlands or the UK. And so each of those, it's a dynamic thing. And then the blue dot is always the United States. So I took a screenshot a couple months ago and I used it for a different slide presentation. But I made sure to be like, in the real thing, it's a dynamic and you can see what's actually happening. But in this, it just shows that the US is the lowest. So
can you click on it, Sandra? You just have to click on the left column right above the one you have highlighted.
The left column.
Yeah, go to the
Yeah.
previous slide.
Oh, the previous slide, this one?
Yeah.
Yeah.
We're not moving with you if you're changing. We're still on the a different.
I've got avoidable deaths per 100,000.
Somehow we're not
It
sharing
says
your
it-
screen anymore.
It says my screen is, it said my screen was
Yeah. So
paused.
good question, Allison. It's a screenshot of what is a dynamic thing. So
Okay, this should be better. Now are you seeing avoidable deaths?
Yeah. And then the one right below it.
The dots. Okay,
Oh
good.
yeah.
And here's the US at the bottom. This is my very favorite one. You may not like it. Some people don't like seeing this tangle, which reminds me of my hair in the morning. It reminds me of bed hair. But the point is that all those lines are other countries, and the United States is the red line. Why are we outside the tangle? Why are we so different? So these are examples of how you could follow through on if people are very interested in quality of healthcare. Here are some slides. You could choose the ones you like the best and show them. If people are very interested in affordability, here are some slides. This one, I like this one because even though the numbers are a little out of date, the United States line, of course, is on the top, costing the most per person. And it's above the tangle of all the other countries, which are very similar. But it's double. It's double. It's not $10 higher. It's not 5% higher. It's double. It's 100% higher.
And all those other countries have universal health care.
They
Correct.
all do.
Yeah.
They all do.
I want to throw it.
Every developed country in the world besides us has universal health care.
I just want to recall the caution that if we do show how badly we're doing, it sounds a little unpatriotic to certain audiences. So it might take a little bit of caveat of that we're not being overly critical of the United States. And if you can get into the system, it's the best system in the world. But the problem is only about half of or a third of our population can really get in there. So you have to, I think, soften it a little bit when you show bad stuff like this.
On Blue Sky, all of my messages to do with universal health care begin by explaining healthcare is not the problem. Access to healthcare, which is controlled by monopolistic insurance companies.
So there's more. This is in cost increase over time. This has a 0 at the bottom. It's doubling. I mean, costs are going up at an extraordinary rate, going up 40% in 8 years. And these are just various slides you can have on that topic. Drugs cost more. Drugs cost sometimes 10 times as much in the United States as they cost in other countries. People might want to talk about that. Some people really want to talk about that. And then when we're talking about affordability, another theme to bring in is people skip healthcare because it's so expensive. What percent of adults skipped healthcare because it was so expensive? And how many more are skipping healthcare now than when the ACA passed? I mean, you'd think the ACA, otherwise known as Obamacare, many people think that fixed everything, but it didn't. More people than before are skipping healthcare. This is another one of my favorite slides, but it might be too wonky for some audiences. The other countries are on the left and the United States is on the right. Oops, but the black is people with low incomes and the blue is people with high incomes. How many of them have a cost-related problem accessing healthcare? In the United States, 50% of people with low incomes have a cost-related problem. That's 50% is a lot. But 27% of people who aren't classified as having low incomes have a cost related problem. And that's more than the high income, more than the low income people in the other countries. That is, our high income people, higher income people, have more trouble paying for healthcare than even the lowest income people in the other countries with universal healthcare. This may help
Bruce,
people understand that we have a problem. Bruce.
yeah.
Yeah.
When you say accessing, I don't know exactly if you mean getting to or
No,
getting healthcare. You know what I
getting
mean?
healthcare.
Okay.
That's kind of a technical word, isn't it? That's the word that's used in the
I would
source.
probably say, yeah. Okay.
Yeah, that's a good point.
Just a comment on that last slide that showed adults skipping care, age 19 to 64. It doesn't say if those are insured or uninsured people, but since the uninsurance rate is somewhere less than 10%, and they're surveying all people 19 to 64 years old, a lot of these people are insured or quote have insurance.
Yep.
I don't know. Am I making sense?
Yes, and that's a really important point. We don't have 40-some% of Americans skipping healthcare because they lack health insurance. That's not the case.
Right.
They
Right.
are underinsured is what is the word that we'd like people to learn.
Or they can't afford their prescriptions.
Or
By
they
the
can't,
way,
right.
Are prescriptions going to be covered?
Yes. I have neither the task force nor the governing board has yet gotten around to doing that with detail, but the big assumption is that a statewide system will have such massive purchasing power that they will be able to purchase drugs for Oregon Health Plan or for our Oregon Universal Health Plan members at a much lower cost. And there's also talk about how to engage with the pharmacy benefit managers who are not going to gouge the program for their own salaries. Let's get out of this into something else as we can. Bankruptcies is another issue that indicates that our costs are so high. But the next question you want to ask when you're saying the system is inequitable, it's not affordable, it costs too much, is why are costs so high? And there are some interesting slides in here that might help people understand. There has been research on all the claims as to why U.S. healthcare costs are so high. People go to specialists. People go to the doctor too much. Whatever. There are all kinds of these different allegations as to why healthcare costs are too high, and all of them have been refuted, mostly by international studies that show other countries with lower health costs have patients with even worse behavior than in the United States. The one thing that really stands out, United States different from every other developed country, is administrative overhead. Now remember that healthcare cost per person in the United States is twice as high as in other countries. But administrative overhead in the US healthcare system is 5 times as high as it is in other countries. It is very clear that administrative overhead is the outlier that makes the United States be the red line below all the other lines. And that's why our movement is so focused on revision in healthcare finance that will reduce administrative overhead. It's as if we had a healthcare Elon Musk who would come into the healthcare system with a fancy dancy chainsaw and cut through the administrative overhead and give us a lower administrative cost.
I just wanted to comment. Yeah, this is per capita 5 times, not
yes.
The total
per
population.
Capita.
So that might be of interest to some people.
That. We better fix that right now.
It's in the notes below it. You just pull it up.
Yep. Well, we'll have a little work here to fix the slide, but that's an important thing to have.
Yeah.
This is I have a very nitpicky suggestion, which is that like I can see that the image for the other countries has been shrunken a little, and so it makes it seem like if it really is $5 signs compared to $1 sign, it looks like in this slide we have purposely shrunk the $1 sign to look smaller, even though it's not. So
Good point.
Oh, that's a good
Yeah.
nit.
We can expand that to a normal dollar size.
Yeah,
sure.
we better fix that. This slide, by the way, was created by our very own Mike Huntington and discussed several times by our team on how to make the point. The next slide we got from somebody else and promptly have been told, don't use this slide. Business leaders do not want to see business leaders demonized because of their high salaries. They don't mind often if we demonize the system that prioritizes profits over patients, but they don't want us to demonize.
Somebody
business
might
leaders.
shoot them.
That's right.
Yeah, yeah. On the other hand, if you're talking to an extremely progressive audience, they love to demonize corporations and corporate executives. That's the only time when I think it might be, you might want to think about using that slide. And here's more information about CEO incomes and so on. Here's the high cost of drugs and pharmacy benefit managers. I think this might be the last issue on why is it bad? What is the problem with access? Monopoly corporatization of healthcare. Are you all aware of what this is about?
Now they're buying up all the doctors.
It's right. These 4 cities are either very recently or right now having serious problems with mergers or with private equity buying up a medical practice. Doctors going along with it because guess what? They don't have to mess with billing because the corporation will take care of all that administrative crap that they don't want to do. But Eugene in particular suffered such a loss of physicians that patients got letters saying, sorry, we don't have any doctors for you anymore in our system. Go find a doctor somewhere else. If you're in or near one of these cities, you can get specific information on it, and you might want to have a particular slide. This Eugene slide is an example of the kind of information you might want to mention to people who are in that area, in the Eugene area, for whom it would be important. But you don't want to talk about five different cities in Oregon. You don't want to talk about them all. But even Coos Bay, right out there on the ocean, in a very red area, may have to deal with this. Okay, so at some point you want to stop talking about how the values are not being fulfilled in the system and talk about what the solution is. You can talk about legislative actions. You can talk about the governance board. And at some time we might want to do something to make sure all this information is shared in a way that's very helpful to our conversation leaders. What's the nature of the plan? What's the nature of the things you can do? And then end with the call to action. So thus ends part 1. Uh-oh, I think we're over time. The other part that I was going to do, I think we've already talked about, but we talked about doing this as a persuasive conversation. How do you define that? In speeches, a persuasive speech is held in contrast to an informative speech or an entertainment speech. And I used to teach public speaking, and you try to teach students to do all 3 of these. Some are not as good as others at entertainment. But what makes a persuasive speech different? And I think for our team, for the statewide team we're building, the important difference is, how do we want the people who are there to feel when they leave? We want them to go home saying, this is my kind of movement. I'm going to support this. I'm going to work for this. I'm going to tell my neighbors about this. That is different from going home and saying, oh, wow, I really learned a lot today. And that's different from, oh, that was fun. I could do that again. The biggest problem we've had, I think, in Speakers Bureau situations is people will go home and say, oh, I learned a lot, but then they'll file it in some back drawer in their memory, and it won't affect their activism. So we've got to move people to the point where they're not just being informed, they are becoming advocates. And this is a question for us to ask, is what makes a presentation persuasive? How do you do that? How do you get people to the point where they say, I want to do that? One of the ways to do that, ways to have a community conversation about that, is for us to talk about and recall presentations that we've been to that persuaded us and ones that didn't. We might find a lot of reasons. I don't think we have time enough to do that tonight, but that's something we might want to do some other time. The one thing that we have really worked with in our team is the idea of audience engagement. Now I lost the little line. There it is. Audience engagement is a concept that I've been hearing a lot from in social media and advertising worlds. The idea of when you send out an email, how many people open it? If you send out something and they're reading it and it has in it a link you can click on and get this more information or something like that, or make a donation, how many people click on it? That's a quantifiable form of audience engagement. But the idea of audience engagement, I think, is still relevant for our community conversations. How do you do it? You got to, we think it relates to focusing on the audience and being responsive, listening to the audience, also leading. In a community conversation, you want to let people go where they want to go, but you want to have enough control over the shape of the conversation that you're going to get back, you're going to stay on topic, which is, this is the movement you're going to give your heart to. How do you engage? Think about that. Go back to what worked for you and what didn't work for you. And we share with other people, talk with your friends at home if we can't finish it in this conversation. But one thing that we're really big on is do not read. Do not read anything. Never read anything. Do not read your slides. Do not read your notes while the people are looking at the slides. Keep looking at the people. And in order to be able to do that, you have to practice. You have to ask questions, listen, respond, and lead. Now, this is a really important one. To focus on the audience and choose the slides and words correctly, you have to know who's in your audience. And that's part of the preparation before you start the event. There are several things here that you want to know. You want to know what's their politics. How much do they already know about healthcare? Do they have business, labor, or faith affiliations? And you probably will want to know more things, because when you know these things about your audience, you may change your language. We've talked about slides that are not appropriate for a business and conservative audience, topics we want to avoid. There are a lot of topics to avoid for a business and conservative audience. Don't talk about how we're going to have to pay taxes. Don't talk about anything that stirs up images of government-run or worldwide movements. But what you might talk about is freedom, avoiding waste and fraud, saving money for taxpayers. For progressive audiences, it's going to go. Equity, fairness, and transparency are really very big themes. And you might put things in here to castigate big business that you wouldn't put in if you didn't have confidence that your audience was progressive. Rural people believe that they care for their neighbors. They believe that they are more caring than urban people. They want fair access to healthcare. They think they don't have it, in part because some of their clinics and hospitals departments are shutting down, even as we speak. They don't think that healthcare facilities are fairly distributed between urban and rural areas. Those are things that our plan can build on. The whole idea of caring for your neighbors can be expanded into support for universal healthcare, rather than letting universal healthcare be set up as a threat to caring for your neighbors, as the opposite of it. There's marginalized people, you probably know what the stories are, and we have two other sets of slides, one for a faith audience and one for a labor audience, that touch on the key themes and the key texts that are of importance to those particular audiences. And I hope we may get some more.
Colin's got his hand up.
Yeah, thanks. I guess I just wanted to bounce an idea about, like, you can't, I don't think that I'll be able to determine before I'm speaking to people if I think they're progressive or if I think they're conservative, right? And so I'm probably not gonna use these slides or other slides for those audience because like I want um people to come from all like backgrounds, right?
Mhm.
And so uh and to more on actually could you go back one more slide with the notes about uh thank you. Oh, excuse me, maybe one more. Uh Anyway, there was a note that said, "Don't talk about taxes."
Yeah, yeah.
If somebody asks about a tax, I'm not going to not respond. I want to give the most clear, concise, correct answer to the question about taxes. I wouldn't probably, I don't think I'll ever bring it up in my presentation, but if somebody asks me that question, like I'm going to mention, but this is what I have said and what I will say going forward was like, well, the Finance and Revenue Committee is reassessing the initial plan from 2022, but probably it will be a payroll tax contributed to by employers and employees.
Mhm.
That's like concise, accurate, indicates that I don't really know, but it's like being,
Mhm.
worked on currently. So I just wanted to say that, yeah, that like
Although,
to a degree, like I
although
can't avoid talking about these things if there's a direct question.
that committee is going to seriously discuss, can we call it a premium instead of a tax?
Love that.
And can we get away with it politically? I argue strongly. Let's call it a premium. Everybody knows a premium is what you pay for insurance. That's what the dictionary says. Premium is
They'll
what you pay for
also
insurance. That's what we're going to do. Let's call it that.
they'll also consider an income tax and fashion in a way so it's not double taxing people who are getting a payroll
Mhm.
tax.
Mhm. Yeah, but if we, to the extent that we can avoid the word tax ourselves, you're right. We've got to respond to it if other people bring it up. But I think saying, wait, why call it a tax? It's what you're paying for your health care. It's the equivalent to your insurance premium. Let's call it a
Yeah,
health care premium.
Bruce has
Just,
got his hand up.
So is it going to be a progressive tax? Will it be graduated up with income? And
yes,
another question is there going to be a cap on it?
don't know. The governing board and its committees are committed to having progressive taxation.
Okay.
They have not made any decision about a cap, but
Yeah.
they are very aware that what they propose has to be approved by the legislature, and it's probably going to have to pass a ballot initiative.
Yeah.
And a cap is going to be politically more popular than having no cap. So I suspect that's where they're going to go. But you can have a progressive cap.
And there's a cap on the bottom, from what I
Yeah,
understand,
yeah.
at 2 times the what do you call the poor level?
Federal poverty level.
Federal poverty, right?
That's what the task force recommended, and it hasn't gotten a lot of blowback yet. So
Well, that's
this is
important to know because there's a lot of people that are down there that are worried about it.
yes, a lot
So
of
you
people
got to
worried
say
about
that
Texas,
part.
and
Yeah.
Mike and I had planned to have some breakout groups. This might be something you would want to practice with your friends. Get 2 people together and say, I want to practice this thing from HCAO. I want you to join with me. I'm going to try to lead a brief conversation on a topic. You choose your topic. And I want one of you to pretend you're a skeptic, like a conservative Democratic skeptic. And I want the third person to just watch, observe, take notes. And after I'm done with my 1 to 2 minute presentation, let's talk about it. Let's have feedback. Let's talk about what worked, what didn't work. All 3 people together. This can really help with what does the audience think. The thing about the audience, how do you find out about the audience? You don't know. You got to ask the organizer. Ask somebody in the community.
Listen to the audience; they'll clue you in.
You can listen to the audience, but before you go in, you're going to set up your slides, and you got to know whether to leave the CEO salaries in or not. And whoever's helped you locally is going to know some things that will be helpful to you. Colin, I have no clue what you're going to do if you have a very mixed audience.
I have a trick that maybe others use at the beginning. Say what do you want to be sure that we address today before we part, and have somebody take notes and maybe just get 3 ideas. And you'll get a flavor then of what they're most worried about. Probably cost will
Yes.
be one of them.
Yes.
And then at the end, you can go through those concerns and say, did we address this? And if one of them was not addressed, then you establish a contact between the speaker and the questioner and answer that direct with an email or a phone call or something.
I think the way you phrased the question, what are you most worried about, is really good, because people know what they're worried about. And sadly, they're more in touch with what they're worried about than they are in touch with what kind of a good world do they want. But that is a very good question to start with. Mike, I won't take full responsibility for this because I timed on my part earlier and it was way shorter than this. But all of us have been talking a lot, and there's not much time left for you to talk with us about cost savings and action.
Well, fortunately, a lot of the discussion about cost savings you addressed, or we all addressed, and the slides that I came up with, I came up in the last hour. And thanks to John Rickard, I went to Perplexity. So don't run and hide if you hear AI. And so my first question to Perplexity was, let's see if I can bring this over. Has a series of questions for Perplexity. Can you see my screen?
Yes.
We know that there can be billions of dollars in savings to a large population under a single payer healthcare system. What factors would help us estimate the savings that might occur to individuals? Because people you talk with, like I did today at the mattress store, they'll be glad to hear that it'll save Oregon $1 billion, but it'll mean very little. What's it going to mean to that man with his family if we have a system like that? So here's what Perplexity said. Well, there's quite a few factors involved. You may want to ask that person to find out how much are they spending now, and we actually have a form that would help people fill that kind of information out. How much is insurance? How much out of pocket? How much is your employer contributing, which is really you, because it's part of your benefit package? Where would there be potential reductions in the cost you're paying? And we just talked about administrative savings. We could probably cut the administrative costs in half with single payer. We would reduce prices through drug negotiations, drug price negotiations, and elimination of the huge profit margins. So these are kind of things that would directly affect each individual, even though you can't go away from them saying your tax is going to be 10% or any other number. You can give them an idea of, make them think of what they're paying now, and for these reasons, it's going to be probably less. And then other factors are, demographic factors, how much they utilize or use healthcare now, their income, their age, health status, how comprehensive the healthcare system is going to be, and how well the providers are going to be paid. So I've put the answers into a set of slides that are separate from what you've seen already, and you can work through them and substitute some of them into your other talk if you wish. Oh, let me just show you what I did. These slides are the result of Perplexity. Took me an hour. I asked all those questions, and then I went back to them and said, please create a set of slides that what you've just told me. And basically that's what you see here.
Oh, they made the slides.
Yeah. Let me go back to the top here. So you start here. This is By the way, this is Google Slides. We find is probably the most universal available. PowerPoint, not everybody has, but this is Google Slides. So this set of slides starts out with key sources of savings. There's administrative efficiency, lower drug costs, reduction of fraud. If you have everybody in one system, it's easy to see who's an outlier. So look, for example, if there's 10 surgeons in a hospital and one of them is doing twice the number of appendectomies as the other, it could be for very good reason. Could be his or her demographic that he works with, or it could be that that person is doing too many appendectomies on too few indications. So that's another benefit of single risk pool. That's keeping track of everybody's activities. Then there's projected savings. There's benefits of universal coverage, improved healthcare outcome. We've been through that. But potential challenges we will need to think about coming from healthcare providers, specialists that expect that their income is going to drop. Of course, the insurance industry, and then the cost of transition. So if we pass this tomorrow, it's going to take a couple of years to transition. So in a way, it's supporting two systems for a transition time, which is going to be expensive and complex. But we will have to have a transition time. Challenges from stakeholders, don't like that word. Financial and economic challenges. The legal aspect of it, like getting waivers for ERISA, that's the Employer Retirement Insurance Security Act, which could prevent states from creating their own system that requires everybody to be in it. ERISA would protect union members from having to go to a single system. So we have to get a waiver for that and for Medicare. And the delivery, what would our system, how it would affect delivery of care? Those are pushbacks, probably. People are going to have to change the way they deliver care. The public perception, this is socialism, this is communism, or just plain inertia. Very hard to change habits. And then the implementation we talked about, including the transition time. Then I already talked about the potential savings for individuals, so I don't have to go over that again. Any questions?
It's great. This is a great starting place for slides and conversations, I think.
Where do you want to go from here? I want you to be part of this team. What are we going to do? Bruce.
Okay, so it occurred to me that I could learn an awful lot by listening to these experienced speakers. I would really enjoy being in a real audience with real, victims, listening to Mike and get to hear how he answers questions. And so I think it would be good to be appraised of when and where you're planning to speak so that we can attend.
I will be speaking to a Clackamas group on March. Anyway, I'll let everybody know.
Email.
Yeah.
Well, I'll be speaking in Rogue Valley in early April. But there's more besides us. We're the ones who are fool enough to try to set up this statewide team. There are other people who give great speeches, but they're not on the team building team.
Because this is a spread out state, it would be good to get advance notice so we could plan to travel and be there.
Amanda's got her hand up.
Yeah, great idea, Bruce. And going along those lines, I think it'd be really nice to have some sort of partnership among other kind of new presenters. It's always a little less scary if you have a buddy who can kind of support you. So that might be something to kind of figure out. I know Allison and I already know each other and are easy to connect since we're nearby, but there's other people that are in community together that might be able to take it on. I would recommend it. The other thing that I wanted to mention is I'm a teacher, and so I do a lot of like active learning and how do we, really help people connect with material. And one of the best tools I found is instead of having a traditional setup for chairs where they're all facing the front, actually put them in a circle. And it really does force a kind of, I don't know, force is the worst word, but have people feel a little bit more intimate. It feels a little closer. It's also diffuses. It's harder to yell at somebody when you're looking right at them and sitting so close to them. And then the other thing that I found really helpful is small group discussions. So maybe if we're talking about values, breaking people up into small groups and saying, okay, what did your group come up with? What were the big like 4 values that you talked about that are most important?
So
that
making
way-
it a collection of activities, different kinds of activities.
Yeah, absolutely. It gets more hands-on. It takes you away from being like the speaker expert role even more. And it also diffuses some of the tensions that could arise when you're in a smaller group and you're talking about values with 3 or 4 people versus this big room. I tend to find that people are a little bit more engaged and seem to do a better job listening to other people's point of views too. So, and then they kind of feel like, oh, I've got my team, right? I've got like support here in the room, feel a little more comfortable than they don't know anybody. And the last thing I'll say is just doing quick introductions at the start sometimes can be just a nice way of like, where are you from? Where do you work?
I think we started a little bit
Oh,
early on
did I
that
miss?
because we
I'm
started
sorry.
before everybody
Thinking
got here.
dinner.
We,
Okay, perfect.
I'm afraid
Okay, I'm done.
we were so eager. We
No,
were eager
that's
beavers.
great. That's great. Sorry to be late.
Amanda, do you have a lot of references about active learning? I'd like to know more.
Yeah.
If you could just share more ideas, because active learning is pretty much how you create engaged audience.
Yeah, absolutely. I'm still learning myself. I've only been teaching like 3 years, but I certainly have some ideas I can share. Yeah, absolutely.
Okay, good.
Yeah.
Good.
My talk will be in Oregon City on Saturday, March 29th. I'm afraid it's not going to be on Zoom. It's all in person. Maybe I could persuade them to turn it into a hybrid because we have the owl and so forth. If so, I'll let you know either way.
The very first years, I went to a speaker training organized by Mike Huntington. It might have been 10 or 15 years ago. It was a while ago, 10 years ago, maybe. Mike piled some people in his car and drove from Corvallis to Ashland and trained all of us there who assembled. But we committed to be there all day. We arrived right after breakfast. We were still together at lunch. We were still working after lunch. At some point in the afternoon, late afternoon, we broke and went to another place and watched a movie on healthcare. But if people can get together for that many hours, a huge amount can get done.
Colin's got his hand up.
Colin.
Yeah, I hosted a conversation, or I did a little slideshow before we had this resource in January, and it was the group was only, I did 2 of them, both of them only had about 15 people, and so I felt small enough that if it was 30, maybe I wouldn't have done this, but didn't have that problem, so was okay with that small group. But I guess I want to comment on 2 things that I did that I liked. One, Amanda, is that I want to learn more about active learning. The thing that I did that I think is a component of it is that I said, please ask any question anytime. Please interrupt me giving this presentation because the point is not me presenting. Like, I want questions, I want engagement nonstop, right? And so in one of those 2 groups, they really took that to heart, and the other not so much, but it was still, they're both pretty active. So I enjoyed saying that for myself at the beginning of my presentation, and so I'll probably do that in the future. And the other thing that I did, or I guess I'll do one second point, then my third point. The second point is that this whole thing, our broken healthcare system is like a ball of knots. It's like a whole knotted ball of yarn, and it's impossible to start. There's no right way to start. You know what I mean? So for some person, talking about payment is exactly the right way to hit them in the right spot to have them join our team. For I think most people, that's not exactly where they want to start. Like values works better. So anyway, so it's sort of acknowledging that it's very complicated and it sucks. Um, and so to do that, I said, like, maybe my second or third slide was that this is the combination of government and healthcare, which is the thing that people are most frustrated with, you know? And so just saying that it's okay to be frustrated, it's okay to be mad, it's an infuriating topic. So anyway, that's what worked for me. We wanted to end, y'all wanted to end at 7:30, is that right? I know we've gone a little over.
Does anybody want to stay or have to leave? If you want to talk, I want to hear what you have to say, however long it takes.
Yeah. I just was going to say I do have to go. I've been sort of silently lurking. I have a sick kid at home. I wanted to, first of all, just say thank you very much. We're organizing an event here at the end of April for Bend. So this is really, really helpful to hear this stuff and get these insights, and, you know, looking forward to pushing further. The only thing that I would add from my own experience too, that I just felt worth putting out there, you know, my day job work is in audience development, and you know, most of my work involves trying to get people to do things. The one thing that I have found to be very useful, at least in the digital realm, is the simpler you keep your request and the more direct, the better. And that doesn't always apply clearly, but it's something that I've harped on in a few calls with HCAO, just because I've seen the success of that in my own work. And that's, you're going to have 5 or 10 things you want people to do, but if you can figure out the one thing that can make someone feel like, yes, I can do that, and they can say that right then, you know, that's how you get someone in the door. And once they're in the door, you can help them, you know, you can lead them to do the other 10 things you need them to do. But you know, I have very little experience in like issues advocacy or any of that, so I'm enjoying learning from everyone in this organization. And that's just my own little bit of experience that I like to toss out there. But yeah, thank you all. I'm sorry I have to leave now. I'd enjoy to keep the conversation going. And yeah, take care. See y'all. Bye.
Are you leaving? Are you okay? I think Mike and I need to send you an email with some questions on it. Mainly, what worked and should we continue to do, and how can we make this stuff even better? And is there anything you think we should do quite a bit differently?
I'll send the video if you want to put it on double speed and find things that you're interested in, you can do that.
It's great to have Mike and his
There'll also
technology
be
knowledge here.
an Otter AI summary, like it or not.
Do you think you're going to have AI summarize the tape of our meeting? Is that what you are? Yes. Okay. I'm not sure I'm ready for all
Oh,
this.
it's amazing what they can do. They can transcribe it for you. I can do that right here.
Transcribing, I don't mind, but to try to summarize it, summarizing isn't.
Well, you have to edit it. I mean, it's not going to have
you
everything
definitely
right.
have to. You know, I forgot to mention when you asked me to introduce myself, I've been doing tech work all day, and I gave you the wrong introduction. Just really quickly, when I lived in Olympia, I reestablished the Olympia the Thurston County chapter of the ACLU there in Olympia. And I'm just going to mention 2 things. And the other thing was I've been pretty active with ROP before I started my last job here in Oregon. So those 2 audiences I'm pretty familiar with. And I was very impressed by that very workable framework for someone's slideshow. Yeah.
Where's your home, Bruce?
Well, we live in an odd place where my wife grew up. The route to Tillamook, Route 6 off of 26, goes over the mountain. Well, when you get over the mountain, before you get to Tillamook, right, just 9 miles from the summit, is a little place called Lee's Camp. It's in the middle of the Tillamook Forest. And Mary's ancestors settled here in 1889, and we have over 300 acres of timber of tree farm, and we live right on the North Fork of the Wilson River.
Wow.
It's just hell. It's terrible to live in.
Yeah, right. Yeah.
And Hannah, I forgot where you are.
I'm in Cottage Grove in Lane County.
Oh, that's right. Okay.
Southern Lane County. Yeah. And I also, Bruce, have begun recently volunteering with ROP. They're excellent.
Mhm.
And actually, that reminds me, they're doing their they have like a summit that they lead every year where they bring people from organizations that are affiliated with ROP, which they're currently 91. Anybody who wants to participate basically goes for the weekend for this organizers summit and spends all weekend thinking and planning and working with ROP on whatever, like whatever it is that you're trying to work on. And so, that's something that I've been kind of interested in doing potentially, and is something that we could maybe think about applying to this specific endeavor of like,
Yeah.
making a plan around, okay, what content do we want to have? How do we want to deploy it? How do we want to train people? What does that actually look like? And yeah, so they're going to be kind of creating a space to do that sort of thing. So
Hopefully we can get each other's email and get in
yeah,
touch. Yeah.
yeah.
When is
ROP
that?
cool.
When is that retreat scheduled? April
It is April. Let's see here.
25, 27?
Yeah, I believe that's right. Yeah. hmm
And where is it going to
Where?
be?
Oh, let's see. So I've got to find it on the website again. Here we go. Rural Caucus and Strategy Session. It is.
Oh, in Baker City. Oh,
Yes. Yep. Yeah, April 25th to 27th.
That's
wow.
that's in a low population density area of the state.
Yeah, Baker County, totally. So
Yeah.
will be a trek.
Yeah. But Baker City is so cool.
I'd really like to bring the message there. That would be great.
Yeah.
Yeah. And I haven't been, so after I finished building the house, I cleared the forest and built a house. It took me 4 years. I went back to work. I worked at the BLM for a while. But I kind of dropped out of being so active with other things. So I haven't really been active with ROP since 2011.
Okay. Yeah.
But so that would be great. I've been thinking about it.
Cool. Yeah. Well, they're still doing their thing, going strong. And I mean, that's another, just the connections to the other, human dignity groups that are affiliated with ROP could
It's
be helpful for
a
us
great hub
in
and
getting our
spoke sort
message
of
out.
thing.
Yeah, like we can connect with those groups and they already have communities in all of these different places across rural Oregon.
Mhm.
So we could plug into their communities to bring people together for these community conversations, for example.
Yeah, we
Baker's-
marched. We marched from we marched to Salem. It was during Bush W's term. Yeah.
Baker City is the poster child for our healthcare system, having lost their birthing center a year ago because it was
Isn't
not
that
profitable.
amazing?
Birthing centers aren't very profitable. But then, of course, I think we already mentioned that most of the hospitals east of the Cascades are in trouble financially.
And the reason they're
Wow.
in trouble is mostly through our administrative costs. And that if we emphasize that,
I need to
the-
head out, but I appreciate everyone. I'm just very tired and I need to lie down.
Yes.
So have a
It's
great
time.
night and thank you
She's-
all.
Allison is
Thank
the
you.
new city councilor for Corvallis.
Nice.
Yeah, it's been a long week, but yeah, this is really great. I look forward to the follow-up. Very excited to be part. All right, have a good one.
Bye.
One of the things I learned in this healthcare for all movement is the idea of global financing for hospitals. It makes so much sense to provide stability and funding for hospitals. It's based partly on capitation and partly on what kinds of people come through the hospital. but they don't have to falsify their records to, to code up to get more money. Global funding seems like a thing that will really help Oregon hospitals.
I'd like to learn more about that.
Yeah.
Our CEO here at Samaritan favors the idea of global budgets. He's conservative, but he knows that rural hospitals can never keep up with income, especially during a pandemic. And that's really one of the reasons the Corvallis Clinic went under, is they couldn't bring income in. But if they were under a global budget, they would be prepared for a pandemic, and they wouldn't have to sell themselves to the devil when they are going broke.
I'd be happy to read more if you want to send anything to me.
I will.
Yeah. That's a good. Where do we send people who want more information? Well, Michael sends you something.
Yeah.
There's, and you could just Google it too. Global budgets for hospitals. There's quite a lot written on it.
And you could go to Perplexity too. But I will send you something.
Check the sources.
Yeah.
Should
well,
we?
I just
Go
want to
ahead.
say that quickly, Sandra. The very nice thing about Perplexity is it gives you sources. So for
Yes.
every significant comment that it makes, it has one or two resources, and you can go and say, oh, okay, that's the World Health Organization, or that's Kaiser Family Foundation. I trust them.
Yeah. Yeah, I
Follow
use
through.
it in my work. I'm a scientist, and I've found that it is the best in terms of giving you real resources. And when you ask it science questions, it actually gives you primary literature. Like it gives you research papers, not
Now-
just like,
Now
just
you better
off the internet.
check every single one of them. Click on them and make sure they're really there and they're really there.
Yeah.
Because we did an experiment here with a question about lizards, and this was with Chat GPT, not with Perplexity.
Yes.
But Chat GPT not only answered the
Hallucinates.
question differently, the two different ways we asked it, they made up sources. They made up journal names that
Very
sounded
good at it.
scientific.
Very, very good at it. Totally.
And Perplexity
Yes.
won't make stuff up. Is that what you're saying?
No. So Perplexity was built by scientists, and the goal specifically was that it was actually going to pull information from specific resources and give you those resources, and they would be real. So that's the problem they have fixed.
Okay.
But it's still,
Real
you still
stuff.
want to check though, because there's a lot of information in there, and you just want to make sure that like what it pulled out and summarized is actually what the thing is saying. It's pretty good at that. Like I don't know that I've found an example before where I'm like, oh, I don't know. So it's so far it's been very good.
You do have to hold your nose a little bit because it's owned by Jeff Bezos.
Aren't they? They're all owned by somebody that's you probably don't like. Unfortunately.
Well, we also need to think about where we need to go. What would be our next organizing steps for our team of community conversation leaders? Do we need to have more Zoom events like this? Do we need to have Zoom events that are different from this? Do we need to have some other kind of team building activity that would help us get our statewide team of people who can lead community conversations and help others learn how to lead community conversations? What do you think our next steps should be, Colin?
Yeah, I think the only way to lead is by doing, or so a thought I had is that if we are like Mike, I'm not going to do this, but for your talk at the end of March, if there is a Zoom component, then other people who are interested in having these conversations or being conversation leaders could clue in and like watch a couple of examples. Like Bruce, hopefully you could watch Mike's if that's possible. So having as much as possible, like the opportunity to watch each other speak is good. But I think that we gotta get out there and learn from our mistakes. Like I made mistakes in January that I will not do again, So yeah.
Teach us.
Oh,
teach us what not to do.
I mean,
We'll
like
find
I'm just, I'm different than you are, and so like the way that I feel comfortable speaking, like I said right off the bat, I mentioned that it's complicated. It's like that it's like a ball of snakes, and mentioned that I want people to engage right off the bat. So that was like my need to feel comfortable like speaking to people. So yeah, I blacked out for an hour, so I can't dictate, literally, tell you my mistakes, but they were many.
I would think that starting out by saying that it's complicated and there are challenges, that I think that's a really good thing to do for just about everybody. It is not the universal opinion in HCAO. There are some people who think we will scare people away if we tell them it's complicated, and instead we should make everything.
Yeah, everyone I've ever spoken to says it's
I'm with you,
complicated, so
Colin. It's very
Part-
complicated.
yeah.
Oh,
Maybe we'll
also,
scare away some people, but we'll get some others.
also, I appreciate Colin's feedback on the slide with the dollar sign. And there's probably lots of other things you could see on the slides that might make it clearer if we tweaked it or replaced it. So please send us your feedback on the slides. Did everybody get the full set? The whole 185?
So I
Okay.
believe that's downloadable from Google, and you sent us the link. I'm still have to do that.
Okay.
Okay.
I'll resend it.
And what you have is an older version. I made a whole lot of changes in it yesterday.
Okay.
Oh, good. Resend it.
There are changes made to that slide deck multiple times a week. So it's constantly evolving, which is a good thing. I think
Save
that it means
Yeah, save the link.
The link should take you to the most recent one, right, Mike?
Yeah.
Yeah, okay.
I have two short comments. To me, I've done quite a bit of speaking. Well, quite a bit. I've done a bit of speaking in front of people on issues and getting their support for things. But I find I really like a framework. Mostly though, the more I know, the easier it is for me to talk. If I know what I'm talking about,
Amen.
then be open to questions. So the one thing I would suggest, so I would be interested in, is if you want to meet like this and pick a section of the information that we want to know and just drill in that for that meeting. Because
have a series of meetings focused on content and knowledge.
Yeah.
For me, that would be the best.
Oh, yes. Oh, yes.
Shall we pick a date?
I would add on to that too. I don't even know how to go about starting scheduling community conversations. So at least one meeting talking about like how do you even set that up? What groups do you target? That kind of thing would be really helpful.
So HCAO's mobilization committee and especially the team called Chapters and Beyond is starting to work on that. We had Nick here from Bend. Bend is one of the places that team is working on. Maybe we should just get you to be on that team. Or do you just want to know what they're doing?
Yeah, it would be nice to know what they're doing. I'm on a lot of committees right now.
Okay, you're busy.
Thank you.
Yeah, she's helping organize students at OSU.
Yeah, we've got a younger adults group, and that would be another question that I can ask offline. I was just going to see if maybe we should do the same training for those group members, because I think we could get all 12 of us all fired up and ready to lead presentations.
They're the best ones to speak to that crowd.
Yeah, that's what I'm thinking.
They really
they've been doing a great job too. They're so impressive. Oh my gosh, I wish I was that amazing at 20, but it's really, really cool to see.
Yeah. Oh, Colin's got his hand up.
Yeah, I wanted to respond to two things. Gosh, what were they? Oh my God, my mind has gone. Sorry.
You're not old enough to have that happening.
Whatever. Oh, as far as like lack of knowledge, I think like memorizing how to say the four subcommittees, and the four subcommittees of the governance board are the Community Engagement and Communications Committee. There's the Finance and Revenue, the Plan, Design and Expenditures, and the Operations. And so for like the categories of like what's going to be covered, well, there's the 2022 recommendation that is being reassessed by the Plan, Design, and Expenditure Subcommittee. How much is it going to cost? Well, there's the 2022 recommendation, and that's being reassessed by the Finance and Revenue Committee. Like, there's no way, like I've sort of given up on like knowing I will
Mm.
never know until the report is done. But for the time being,
I
there's
want
four
to know
sub-
that stuff.
Exactly.
Mhm.
Yeah. So go poke around on the Universal
Okay.
Health Plan Governance
But
Board.
that's great. Yeah.
So just saying like, I don't know,
But
but these people are
I
figuring it
hate
out.
always telling them to go, I'm not going to answer you. Go look it up. That's
I should send Bruce
cheating.
my summaries.
Sure.
Yeah. Yeah.
That'd be great.
I forgot the
Send them
second
to
thing,
me.
but Amanda, that's great. Yes, younger people. So
Yeah, good.